So without further ado, I'm going to get the presentation started. And it is my pleasure to introduce our first speaker, Ilona Kickbush, who is known throughout the world for her expertise and has had a distinguished career with the World Health Organization and Yale University. She was awarded the WHO Medal in recognition of her contributions to global health, and she was one of the organizers and participants of the first International Conference on Health Promotion held in Ottawa in November 1986. Ilona, the floor is yours.
Thank you very much, Ian. Hello to everyone, and particularly hello to the old friends who helped develop health promotion in those distant days. It's wonderful to be here and to try and take stock, and even more importantly, to look forward and to learn. I've noted down 7 points I'd just like to raise, because obviously I've been asked to speak about from Ottawa to Geneva, and of course in December of last year there was the 10th Global Conference on Health Promotion, and you could spend a lot of time talking about what happened in 35 years. For me, maybe we can show my first picture. This was me in Ottawa in 1986. There you go. And I was thrilled as a young professional at WHO to be given the responsibility by the Director General of the World Health Organization to develop this totally new area of work for WHO that he saw fully in the context of the Alma-Ata Declaration on Primary Health Care, and where he wanted to make a very, very strong point that primary health care was not just about care and health services, but was about promoting health, was about equity, was about the determinants of health. It took 6 years to get to Ottawa with many, many different meetings, initiatives, background papers, fights, supports, all kinds of things. And what was particularly important from the early days was the very strong support from the Government of Canada, the then Health Promotion Office, and Ron Draper. I think we'll hear more about that. And of course, the Canadian Public Health Association. And it was absolutely essential. That was a signal we wanted to give from the start. You cannot do health promotion without civil society. And that was also reflected in the participants, rather atypical participants, partly as far as WHO went in those days, like the Boston Women's Health Collective and people like that. But one of the things I wanted to say under this point was really the extraordinary freedom I was given as a young professional by the DG of WHO to develop this, to invite whoever I wanted, to be creative. And I sometimes wonder if one would have, you know, that same amount of freedom today. The second thing I wanted to raise was process. Particularly, I've already referred to the many different meetings, ideas that we were able to develop over that 5-6 year period with many people involved. But I also want to mention the process we had in Ottawa itself. The Director General, when I presented it to him, said, "This will never work." And this was Havdan Mala, who was all about participation. So we said that we would really develop the charter on the spot, that everyone would have an opportunity to comment on it, to make suggestions, to help formulate it. And in brackets, I would say here, the various health promotion conferences we had were all linked to a new jump in technology. This was, would you believe it, the word processor, which allowed us to do the Ottawa Charter as we did. Every day we revised it in a team, and the evening We pushed the new version under the doors of the hotel. The next day, everything was collected again. And if anyone's seen the small film, the revisions were still done on the second part of the document while I was reading out to the conference community the first part of the document. Of course, we went in with the 5 action areas, but definitely a lot was changed on the spot. And this, you know, is important for the messages of health promotion, that it's not only content, it's the process. And of course, we always said health promotion is a process. We were heavily attacked for that again and again and again. But unless you have a credible co-creation process, the issues that you take up lose their credibility. And Halfdan Mahler actually in the last session apologized and told the whole community that he had been wrong. One very rarely heard Halfdan Mahler say that he was wrong. My third point is the subtitle of the Charter, which is towards a new public health. We really felt that we would set a new public health agenda, and an agenda that we hoped would not go away, but would be developed over a long period of time. We didn't think, you know, this was going to be established with the Charter, but with this process that I've referred to. It raised many, many issues before its time. Many of them have actually only come to the fore in the Geneva Charter right now. It was the first WHO document to mention ecology. It had, without using the word, a rather feminist slant to it. It was inclusive for its time, and I look to Evan here, because it wasn't as inclusive as it should have been with what we know today in terms of decolonization and other movements. But for its time, it was very much ahead of anything that at least WHO was doing at the time. Feminists, AIDS activists, all kinds of things. And 2 years later in Adelaide, the Aboriginal community actually took the stage away from the minister to say, look, this is our land, health promotion is about us. And, you know, we helped engineer that. My fourth area is that we had a good strategic idea that there should be regular conferences on health promotion every couple of years. The critique was, you know, how global is this concept? And for a whole number of reasons, we couldn't do a big global conference at the time. But the goal was that over a period of 10, 15 years, we would move from one continent to the other and really make it a global development. My sixth point is, of course, that this wasn't a clear progression. This was like this. Particularly difficult was when WHO stopped supporting health promotion and degraded it to be a subcategory of non-communicable diseases. Very, very difficult days. Even in the field itself, where the links to public health were forgotten, where it was starting in some places to be a truly separate discipline rather than a movement that would take a new way of thinking forward. And then, of course, because, as we've said, it was a kind of rhizome, some parts became more popular than health promotion itself. There was a point in time when everybody was on about health in all policies, but didn't speak about health promotion, or everyone spoke about health literacy, but not about health promotion. So the kids went off and left sort of the family behind. My seventh point, and with that I'll slowly come to a closing. The wonderful thing is, since I was comparatively young, as you saw when I got this responsibility, if you're around long enough, you can actually bear the fruits of your work. And so here is the other picture I wanted to share with you, that on occasion of the 10th Global Conference, I was awarded the WHO medal by the Director General for two things: for having helped develop the Ottawa Charter and for making it a key component of global health. Why do I raise that? Because I also wanted to speak about Dr. Tedros and the Charter. First of all, if any of you read the Charter, and I hope you will look at the Geneva Charter carefully, it has set the agenda of a well-being society, which I think was integral without us having the words, the language, and some of the concepts in the thinking of Ottawa, and I think it will really take us forward. It is so much more ecological, as Trevor, I think, will also underline. It is much more inclusive. Many of those things are there. But I think what is possibly even more important is that the WHO Director General this time around has defined health promotion as one of the priorities of WHO. He has clearly said that this will be the priority in his second term. And those of you who are a bit familiar with WHO will know that one of the goals is that to have 1 billion more people lead healthier lives over the next 5 years. So I think we've come full circle somehow from one DG to the next. For me, it's been fantastic to still be around and to be able to contribute to it. And I'd like to thank you again very much for this invitation and look forward to hearing the others. Thank you.
Thank you so much, Ilona. It's wonderful to have that global perspective on what we always think is a very Canadian document, but of course we know that it was a global effort, and the efforts of everyone at the World Health Organization and yourself, most importantly, brought it to fruition. So we're going to go through all of our presentations. I remind people we're going to have a Q&A session after the presentation, so feel free to use the Q&A module at the bottom of your screen to pose any questions you might have. But right now, we're going to turn the podium over to Trevor Hancock, who really doesn't require an introduction to this crowd, but I'll introduce him anyway, as the man who wrote and delivered the theme paper on supportive environments for health at the first International Conference on Health Promotion. And that same year was involved in establishing the World Health Organization's Europe Healthy Cities project. He has pursued these themes in health promotion ever since, locally and globally. Trevor, the floor is yours.
Thank you, Ian, and it's such a pleasure to be here with Ilona and Irv and Peggy, who were there 35 years ago. I'm speaking to you from Victoria, BC, which is the traditional and unceded territory of the Lekwungen-speaking people, and I'm very grateful to be here in a very beautiful part of the world. So I'm going to share my screen and get on with my presentation. So as the title says, this is about planetary health. That's why I want to focus. It fits in with what was just said about the role I played in the conference 35 years ago, and link that to the deeper implications of a well-being society. So let me start with this statement straight out of the Geneva Charter. A healthy planet is essential to the health and well-being of current and future generations, the Charter says very bluntly. And that we have to achieve sustainable well-being and equitable health, and I'm not going to focus much on equitable health, but I want to stress it's there, and it's directed at now and future generations, but without breaching ecological limits. And this is backed up by a lot of recent WHO and other statements. So the UN Environment Programme a couple of years ago now stating that a healthy planet is important for the health and well-being of all people. The WHO Director General, who Ilona just mentioned, talking about the nature as the original source of all clean air, water and food. And I think most dramatically, just over a year ago, the Director General, the Secretary General of the UN, Antonio Guterres, saying the state of the planet is broken. Humanity is waging war on nature, and this is suicidal. This, to me, is a clarion call for what is the challenge to the health, not just the health and well-being of people, but the stability of societies throughout the world in the 21st century. And therefore, health promotion has to be there. Now, as was just mentioned, the Ottawa Charter did include for the first time within what they call the prerequisites for health, what the Charter called prerequisites, a stable ecosystem and sustainable resources. And it advocated adopting a socio-ecological model of health. So as Ilona says, very much ahead of its time, the first WHO document I know of to recognize these ecological determinants of health. But unfortunately, in the years that followed, and as health promotion evolved and then population health evolved, we became very fixated on the social determinants of health, which I'm not saying is bad. It's a very important thing, and the WHO Commission was a very important commission. But in the process, we neglected the ecological determinants. But as the WHO Director General said, Dr. Tedros, the most fundamental determinants of health are ecological. They are air and water and food, and that list at the bottom is some of the ones that we identified 7 years ago now in a report for CPHA on the ecological determinants of health. So we've tried to bring back this understanding. This was the report that, the two reports actually, a discussion document and a sort of lengthy background report on the ecological determinants of health in 2015. And at the same time, there was a report out of the Rockefeller Lancet Commission on planetary health, and the Lancet had been pioneering this idea of planetary health, which is the health of human civilization and the state of the natural systems on which it depends. And I would say that that is as good a definition of the role or the field in which health promotion should be active as any. So planetary health, the ecological determinants, those were ideas. We didn't have that language then, but they were there in 1986. They then kind of fell off the agenda for the most part, and we've been bringing them back, particularly in recent years. So if you look at the Geneva Charter, for example, which talks about coordinated action in 5 areas, 3 of those 5 areas are directly germane to what I've just been talking about. And the first of them is to value, respect, and nurture planet Earth and its ecosystems. That's a very powerful statement to have as the first area of action for health promotion to create well-being societies. Secondly, to design an equitable economy that operates within planetary and local ecological boundaries. And thirdly is to develop healthy public policy for the common good. So these are ideas that are really crucial. I will leave off the other 2, but I will talk about these 3. So back in 2015 in the CPHA paper, we put forward this model of an ecosocial approach to public health action. And you could say health promotion action. So clearly, if we're going to have a well-being society in the way that the Geneva Charter defines it, we're going to need to take an ecosocial approach. The key point here is that social and economic changes, top right, affect ecological changes, top left, but they then feed back on the way that social and economic systems operate. And then both of these together work to influence population health. So we need to take a sort of systems approach that understands that the ecological and the social are not separate, but actually completely intertwined, completely embedded in each other. What we don't often understand is just how radical this approach is, and I'm going to show you a bit more of some of this. But this I actually took from my major paper for my master's degree 42 years ago now, and I had dug into some of these issues and came across comments such as this from Sears in 1964, talking about ecology as a subversive subject. If it was taken seriously as an instrument of the long-run welfare of man, and man was the language used then, I would prefer humans, would endanger the assumptions and practices accepted by modern science, and I would add modern governments and business. So it was recognized way back then, almost 60 years ago, how subversive the notion of ecology is. If we take ecology as the operating principle behind the Geneva Charter, then it's really quite a subversive subject. And it's also quite a radical subject. Murray Bookchin, a famed eco-socialist, wrote in 1970, ecology is intrinsically a critical science, in fact, critical on a scale that most radical systems of political economy failed to attain. And so let me bring this right down to here and now in Canada. In Canada, we act as if we had this, as if we had 5 planets. Our ecological footprint per person is roughly equivalent to 5 years worth, or 5 planets worth of biocapacity every year. And the reality is we only have this. So we are vastly over-consuming and over-polluting compared to what should be our fair share of the ecological footprint of society. What it means, and this is the bit that people don't necessarily grasp, is that we need to reduce our ecological footprint by about 80%, and quickly. And this is a vast social, economic, cultural challenge. And 2/3 of that footprint is carbon, which helps, but there's more to the ecological footprint than just carbon, just as there is more to ecological change than just climate change. But the other thing that's embedded in all of this that people usually don't get at all is that if we're going to go to a one planet footprint for societies around the world, we're going to have radical redistribution, because there is only so much to go around. The planet is finite. There are hard limits to how big we can grow in terms of our consumption, in terms of our pollution. And we're already exceeding those planetary limits, as I'll show in a minute. So if the pie has to shrink, or then the only way that those who do not currently have enough can get enough is for those of us who have much more than we need to take less. So once the pie is no longer growing, you can't hold out the hope of people being lifted out of poverty through growth. It will have to be through redistribution. And this is true both within nations and between nations. And again, is a radical concept that is not clearly understood. But it's where health promotion has to be, incidentally, because essentially we've had it back to front. We've sort of believed that the economic system drives the social system and the ecological system really just doesn't matter. It's actually excluded from most economic models. But the Worldwide Fund for Nature back in 2014 had it exactly right. Ecosystems sustain societies that create economies. It does not work the other way around. We have to stop working as if we believe or thinking that it works the other way around. It does not. So we have to have an eco-social approach, and we have to design an economy that fits within that. A well-being society needs a well-being economy. This is actually the title of a column that I wrote. I write a weekly column for our local newspaper here in Victoria, the Times Colonist. And my column on Sunday was called A Well-Being Society Needs a Well-Being Economy. And a well-being economy puts people and planet first. And again, Antonio Guterres, UN Secretary General, telling us that GDP fails to account for the incalculable environmental and social damage that may be caused by the pursuit of profit. And he went on to say, the life and well-being of the many over the short-term profit for the few is what we have to value. This was in introducing something called our Common Agenda back in September, so very recently. Not a new idea, but very powerful when the UN Secretary General is saying this to the nations of the world. And as part of that, we have to measure what is called, what the UN and others call inclusive wealth. So our wealth is not simply how much cash and stuff we have. Our wealth actually includes our natural capital, the human capital of our own capacities and abilities, and our social capital of our relationships with each other, formal and informal. And so real growth in wealth means increasing all these forms of capital at the same time. And 21st century economies must do this. They must not simply maximize economic growth and economic capital at the expense of the other forms of capital. That is not increasing our wealth. In fact, it's harming our overall wealth. So one model that's become very popular in recent years that I think needs to be at the heart of health promotion thinking now is Kate Raworth's notion of the donut economy. And Kate Raworth was a speaker at the Geneva conference back in December, talking about these ideas. And what she did very simply was to say, look, we have to have a social foundation. That's the inner dark ring. And within that are the largely the SDG goals for achieving social well-being. So we have to have a social foundation, and then we also have an ecological ceiling, the outer dark ring. So you can't go beyond the ecological ceiling. And within those two, the body, if you like, of the donut is what she called a safe and just space for humanity. But note that she also describes this as a regenerative and distributive economy. So she recognizes both that we have to regenerate nature and we have to distribute, as I said earlier, quite radically, in fact, across societies and across the world. This is Canada's donut economy performance. This is from some work by a couple of friends and colleagues and was published just a month or two ago. This is Canada's donut performance. The key point here is all of that red stuff outside of the dark green ring is the extent to which we are exceeding the one planet boundary in Canada. We meet the social foundation, although they're using data that is based on SDGs. So for example, poverty here is measured at $5 a day, which clearly doesn't translate well for Canada. So we're going to have to look at this in more detail and figure out what the how well we meet the social foundation in Canadian terms. But nonetheless, we largely meet the social foundation. We sure as heck exceed the ecological ceiling. That's what we have to shrink. We have to shrink all those red areas down to the dark green ring. And that's the challenge. And that's a health promotion challenge as much as it is anything else. If you want to learn more about ecological economics, I did a report on this with the National Collaborating Centre for Healthy Public Policy a couple of years ago now, and it's available. You can look it up. But what I want to end with is this, that in order to do this, in order to get to a well-being society, in order to get to planetary health, we're going to have to change some deep underlying values that drive our social and economic systems. So what do we actually mean by growth and progress and development? It's not about more stuff. It's about growth in human development, growth in social development. It's the regeneration of natural capital. That's progress and development. We need to think about what is the good life? What is the meaning and purpose? Is it simply accumulating more stuff? Or is there more to life than that? We have to understand we are not individuals alone, that we're all in this together, something that the current disgusting display in Ottawa doesn't understand at all, that we're all in this together. And the whole cult of individualism has to be overturned. And finally, and I think in many ways most importantly, we have to value and respect nature, which is, remember, the first of the 5 actions in the Geneva Charter. And we have to develop a sense of reverence for nature. And in order to do that, I think we have to look at and learn from Indigenous knowledges and values. I'm part of a global working group of the IUHPE that is called Waiora Planetary Health. That is our work group. And we recently published this article in Global Health Promotion on this issue, Waiora, the importance of Indigenous worldviews and spirituality to inspire and inform planetary health promotion in the Anthropocene. So I think we need to be stepping right back and looking at our role. We've changed as health promoters, social and cultural norms and values in the past around smoking, around AIDS, around a whole bunch of things. This is an even deeper challenge to us. We're going to have to get into the business of changing social norms, cultural values, around our attitudes toward nature and ecosystems. And in order to do that, we really need to look at and learn from Indigenous knowledges and Indigenous values. And so with that, I will stop and turn it over to Evan Adams.
Thank you so much, Trevor, for a thoughtful presentation on where we need to be going with respect to the ecological determinants of health and the urgency for the action that we need to be taking. So it's now my pleasure to introduce Dr. Evan Adams. Evan is a Coast Salish actor and physician from the S'la'im First Nation near Powell River, British Columbia. From 2007 until 2012, Evan was the first ever Aboriginal health physician advisor in the Office of the Provincial Health Officer in BC, and then went on to be the Deputy Provincial Health Officer from 2012 to 14. He then served as the Chief Medical Officer of the First Nations Health Authority from 2014 to 2020, and is now on exchange with the First Nations and Inuit Health Branch at Indigenous Services Canada as the Deputy Chief Medical Officer of Public Health. Evan, the floor is yours.
Thank you very much. How wonderful to follow you, Trevor. I certainly recognize that I think some of the actions in 1986 has enabled me to be here and represent the government of Canada, and also talk about First Nations, Inuit, and Métis issues, where all of my public health work has been since 2005. So my name is Evan Tlesla Adams. I'm from Tla'amin Nation, which is about 160 kilometers from the city of Vancouver. And my work in Indigenous public health has been about trying to actualize self-determination, or the right of First Nations, Inuit, and Métis nations to determine their own course without interference from other nations, and the right of First Nations, Inuit, and Métis individuals to determine their own course without interference from other individuals. Let's go to the next slide. Thanks. Welcome, bienvenue, Tanshi, which is a Métis greeting, Atelihai, which is Inuk expression for hello, and Cheche Hatanapesh, welcome, hello, in my own First Nations language. Let's go to the next slide. Indigenous health is a shared responsibility between First Nations, Inuit, and Métis, of course, their leaders and communities, the provinces, territories, and the federal government. First Nations, Inuit, and Métis are asserting their self-determination and their ability to shape their own healthcare system, to shape its quality and acceptability, and they are definitely trying to be in the lead. Some would say they are in the lead, but with their partners. First Nations, Inuit, and Métis should not be left to manage their own poverty, or their own lack of infrastructure, or their historical lack of access, and thus requires participation of all. The federal government provides health services as a matter of policy. There is no legislative mandate to deliver health services. But the federal government does provide health services to First Nations and Inuit, and is trying to explore its fiduciary responsibility to Métis. And it uses its spending powers to set and administer national principles under the Canada Health Act. And the provinces and territories are responsible for healthcare delivery in their respective jurisdictions, and receive transfer payments from the federal government to provide universally accessible, publicly insured health services to all residents, including Indigenous peoples. Not we serve all residents of the PTs except Indigenous peoples, which has been the stance and still is the stance sometimes of certain PTs. Let's go to the next slide. I just want to check that we're on the right slide. Great, thank you. So I work in the Office of Population and Public Health at Indigenous Services Canada. We support a suite of what we, the Government of Canada, consider high quality public health services. That's only our opinion. Quality as determined by First Nations Inuit and Métis is another matter that is still being investigated. What is important to them? And in fact, even the art and science of public health is being questioned as, how does it bend to serve Indigenous populations, since it was invented without consideration of our needs and very, very specific circumstances in the Americas. Health promotion programs that are culturally relevant, or we're trying to make them culturally relevant, focus on healthy child development, social and mental wellness, addictions, and healthy living. And of course, the very specific foci within mental wellness is around Indian residential schools, health support. Let's go to the next slide. So the challenge is stemming from our complex and interdependent health systems are many. It's complicated, but we must mention systemic racism, issues of geography, historic underfunding, a lack of system-wide cultural safety, community capacity constraints, endless cycles of crisis, it feels like, and a rising demand and a rising expectation for equity of services and equity of outcomes for Indigenous peoples. And we as Indigenous peoples and our health and health systems still far, far behind that of the general Canadian population. So still, as of 2018, our life expectancy is still 5 years shorter. For First Nations, for Inuit, it's 10.5 years shorter. Infant mortality for First Nations and Inuit is still 2 to 3 times higher, and our rates of chronic and infectious disease are unparalleled. For instance, tuberculosis rates in Inuit Nunangat are 300 times that of Canadian-born non-Indigenous peoples. Let's go to the next slide. The cases of Brian Sinclair and Joyce Echaquan illuminated anti-Indigenous racism in our healthcare systems. Systemic racism manifested through refusal of care, substandard care, misdiagnosis, or unnecessary, unwanted medical interventions. And as a result, Indigenous peoples are less likely to feel safe within health systems compared to non-Indigenous peoples, and or more prone to avoid or delay seeking care. Drastic changes are required in order to change this. And these feelings and views on historical experiences with the healthcare system are quite longstanding. We have inherited, those of us here in this audience have inherited this, what I call a hangover of the impacts of colonization. And in BC, Mary Ellen Turpel-Lafon's report on anti-Indigenous racism in BC's healthcare system, 2/3 of Indigenous people surveyed, of their tens of thousands of respondents, said that they had experienced discrimination from healthcare staff based on ancestry or origin, compared to only 5% of non-Indigenous respondents. Next slide. So we've had a federal response to anti-Indigenous racism. Our conversation on anti-Indigenous racism actually stemmed from a group of Indigenous physicians who met weekly with Minister Bennett, then the Minister of Crown Indigenous Relations. We were meant to be talking about COVID in Indigenous communities, but we would often turn back to how much racism was affecting our training and our work. And it was very interesting to see this, a group of about 14 Indigenous physicians be vulnerable and to confer and to sort, what was important to them. And definitely racism against themselves and somewhat against their patients, but mainly against they themselves personally, led to 3 national dialogues on anti-Indigenous racism in health systems. And there is a report that was issued after the 3rd national dialogue in June of 2021 called The Federal Response to Addressing Anti-Indigenous Racism in Health Systems. I certainly suggest you have a look. The Federal Response to Addressing Anti-Indigenous Racism in Health Systems. And the themes and recommendations brought forward in those national dialogues to address anti-Indigenous racism echo those provided through other very important initiatives and policy drivers that inform our work. So let's go to the next slide. So these previous reports still inform where we find ourselves today, I think, bear investigation. We should be reading and rereading these reports and their recommendations to see a way forward as far as First Nations, Inuit, and Métis health. So the Truth and Reconciliation Commission calls to action, where the TRC spent almost 6 years traveling across Canada, hearing first-person accounts of residential school experiences. A 6-volume report was the result of that, and the opening of the National Truth and Reconciliation Center in Manitoba, where a lot of these records are housed, where these testimonials, first-person testimonials, are housed, but not my parents. My parents both went to residential school, and I have quite a lovely story of how they were going to finally record their first-person accounts, but stopped to identify children in photographs, because they're both in their 80s and had remembered so many of their fellow students when no one had been able to name them thus far. So in December of 2015, the Prime Minister reiterated the Government of Canada's commitment to implement the recommendations, those recommendations. There was also the National Inquiry into Missing and Murdered Indigenous Women and Girls. And in 2016 was when the National Inquiry started, and the final report, which comprised truth and interviews from over 2,000 family members, survivors of violence, experts, and Knowledge Keeper, did put forward numerous recommendations around murdered and missing Indigenous women and girls. And that National Action Plan has been expanded to include Two-Spirited people. Next slide. So the Indigenous Services Canada, where I currently work, has a strategic plan and a roadmap that defines our vision of how we can support, from the Government of Canada, Indigenous self-determination and reconciliation, and better health services and health outcomes. So it's moving from a one-size-fits-all approach to recognizing distinctions between each of the Indigenous groups. This plan aligns, we think, completely and utterly with the Ottawa Charter for Health Promotion. It's, of course, the Ottawa Charter is very far-reaching, complex, idealistic, and the operationalization of those, especially for profoundly underserved population, is taking a while and has many challenges, of course. Next slide. So health transformation with a capital H and a capital T is the way forward. A patchwork of health programs and services has exacerbated the gaps, and those need to be mended together. And that is a number of tables where complex dialogue happens to identify those gaps and to knit services together, often with partners who are sometimes unsure of their own mandate to step into those gaps and provide a service. Next slide. We, of course, engage fully with Indigenous partners, including the national Indigenous organizations, and we interact, of course, regionally with groups of First Nations, Inuit, and Métis, and we try and work at grassroots level or at a community level, and even with individual clients to try and make change. And the next 3 slides are, I'm going to skip, are around First Nations, Inuit, and Métis models of population and public health. I think those are not for me to describe in this context as a representative of the federal government. I could possibly do that justice. So let's keep going to the next slide. That starts with COVID impacts in Indigenous communities. And as you probably have seen in the last 22 months, COVID-19 has demonstrated to us very clearly the health inequalities and disparities in the social determinants of health in Indigenous populations. COVID-19 has had an inordinate effect, a negative impact on Indigenous peoples, particularly in those disadvantaged sections of the country, like in the prairie regions or in the north, that have driven more of our people into poverty, job loss, higher levels of food insecurity, significant impacts on mental health and overwhelmed health system, greater morbidities and mortality, et cetera, et cetera. And so next slide, the response within the Indigenous community has been strong. And let's go to the last slide, which is the path forward. That we must acknowledge how past colonial policies have directly impacted the health of Indigenous peoples. We must take an approach to the determinants of Indigenous health and offer a framework through which to address inequities experienced by Indigenous peoples across the country, coast to coast, that self-determination is central, and we must revisit the Truth and Reconciliation Commission, UNDRIP, and the Murdered and Missing Indigenous Women's and Girls report, that we need to increasingly emphasize and focus on the resources allocated to health promotion. It's been slow progress, though I think healthy progress. And we must continue to build healthy public policy with First Nations, Inuit, and Métis in the lead, and require us to continue to evolve our bigger picture in our own minds and bigger picture considerations in policy development cycle. Thank you very much. Ima.
Thank you so much, Evan. That was a great presentation, certainly highlighting once again the impact of colonialism on the current health disparities for First Nations, Inuit, Métis populations in this country, and the efforts that we have to put in place to undo the damage of that centuries of abuse. So just remind everyone, if you have questions, we're going to have a dedicated Q&A session after the presentation. So pose your question using the Q&A module. There's too many comments in the chat for me to pick out the questions, so use the Q&A module. And now I will introduce our next speaker. As the coordinator of the Americas region of the Réseau Francophone International pour la Promotion de la Santé since 2019, Sarah Chaput works in collaboration with various organizations and actors across the Francophone space for reinforcing health promotion action. Sarah values the sharing of knowledge and expertise in health promotion in a perspective of sustainable health and win-win relationships between stakeholders. Sarah, the floor is yours.
Thank you. So, well, first, thank you for having the interest to include a Francophone and a youth perspective to that webinar. So just a second, I will display my slides. So we could translate the name of our organization as the International Francophone Network for Health Promotion, if that can help. So I will first introduce briefly the organization I work for and how it's related to the Ottawa Charter. And then I will present some, I'm saying really some, of health promotion challenges that we face in the Francophone world. And I will end sharing some reflections on potential opportunities for health promotion development. So REFIPS's mission is to improve the recognition of health promotion and to strengthen health promotion in the Francophone world. So the organization was born in 1992, so shortly after the implementation of the Ottawa Charter. So we are a network for sharing knowledge, experiences, and tools for health promotion in French, of course. And we also are a network open to actors from different sectors of the society who have a potential impact on population health. So we are really open to different types of actors as we need them to achieve our mission and our goals. So we are really focused on health promotion practice, that targets action on health determinants and the reduction of health inequities, and all of this in a perspective of sustainable development, of course. So, so it's really a few years after the implementation of the Ottawa Charter that REFIPS was born. So a few health promotion professionals from France, Belgium, and Quebec reunited, and they created this organization for two main reasons. So first, because of the importance of health promotion for improving population health, and also because of the lack of health promotion resources available in French. So they wanted to create a Francophone space for health promotion. So the Ottawa Charter is really at the heart of our mission and projects and how we build our projects, and our values, which are empowerment, equity, and collaboration, are really aligned with the principles of the Ottawa Charter. So we are facing some challenges in health promotion in the Francophone world. So I'll name a few of them, and maybe the Anglophone world also shares some of these challenges. So first, we observed, unfortunately, a setback in health promotion in the COVID context. So a lot of health promotion professionals were redirected to other activities and to help with vaccination and with other tasks related to COVID management. And so I think that's unfortunate, because health promotion should have been really part of the response to the crisis. And if it's not, it means that we still have some work to make some advocacy, to make, so it should be natural to include health promotion in that kind of complex crisis. But at least non-governmental organizations were there and kept going, and academics as well. So we also observed some kind of mobilization. So that's what I felt, that health promotion professionals really mobilized. So we need to include health promotion responses. And I heard Ilona saying that this was a WHO priority. So that's a good thing, but now our governments need to include it in their priorities as well, and it should be natural. So that's the first thing. And still, after 35 years of implementation of the Ottawa Charter, we still observe in our community, in our health promotion professionals community, various understandings of health promotion. So sometimes it's seen as something more restricted to health education, for example, or there is confusion with prevention or community health. So 2 years ago, we put in place a global working group to discuss that issue, because we think this is not good for advocacy if we are confused. So it doesn't really help us, including some health promotion approaches in crisis like COVID. So we are preparing a discussion workshop for the next IUHP's World Conference to discuss these issues and to see how we can find solutions and reduce tensions in different settings. So that's a second challenge. Also, we observe a lack of familiarity with health promotion in other sectors and in the larger population. So usually other people are not so familiar with health promotion, and they should be more familiar, as we need them to achieve our goals, and they also are health promotion actors, but sometimes they don't know they are acting in health promotion, but they don't call it like this. They call it other ways. So I think we need to use our leadership to put all of these people together in order to improve population health and well-being. So also, when we talk about health promotion, the word health is very often seen from people from other sectors a part of health promotion. It's often seen as something restricted to physical and mental health, whereas our vision of health in health promotion is much broader and includes social and spiritual health. So I think we need to communicate more this vision of health that we have, and that there's an ear for that. With COVID, I think people from other sectors or decision makers are ready to hear what we have to say. So also, I would like to raise an issue about health promotion core competencies and the need for improvement in advocacy and communication. So we observed many health promotion professionals are not always very comfortable doing advocacy or advocating or participating in advocacy project. A lot of them think that they face ethical issues because a lot of them are working for the government, for example. So we organized a webinar last December on this topic, and it was really popular. So there is really an appetite to improve skills, to improve advocacy skills and communication skills among health promoters. So that's the good news. And also there is still a gap in the available tools in French in health promotion, and we really need more than translations. We need to have adapted tools for the Francophone audience. So we are currently working with the National Collaborating Center for Health Determinants, and we are working on the update of the glossary for essential terms on health equity. And we are doing the process in French, and they are doing it in English as well. And we really see that there are differences in understanding and how the concepts and terms are used in practice. So we really, the more we go on, the more we see the added value of doing the process in French as well. So some reflections on opportunities for health promotion development. So I think COVID-19 and climate change crisis and all the crises that we face at the moment create a space in the public discourse for health promotion. So we really need to make people understand that public health is not restricted to vaccines and viruses, and we need to explain and communicate about health promotions, so we get also so we can advocate and get more funding for implementing health promotion approaches. So I think the Geneva Charter and its focus on well-being also really creates opportunities, because when we talk about well-being and quality of life, people tend to relate better. So people from other fields, when I say people, I mean people from other fields who are out of our sector, they tend to understand better how they can act on this more than health. So I think it's good to use well-being for advocating for more health promotion approaches. And also we observe in our community and among our members a growing interest for strengthening health promotion skills. So there is really an appetite to follow some trainings, to exchange with others. So that's great. So we really need to seize this opportunity to go forward as we go forward. And lastly, we have this technological evolution that creates opportunities for networking and training, so that can really support actions directed to strengthening health promotion skills. So thank you for your attention.
Thank you so much, Sarah. That was a great perspective, and I'm seeing the comments in the chat that your comments about the Francophone experience resonate with the Anglophone world as well. So some common challenges that we can be working on together. So it is now my pleasure to introduce our next speaker, Peggy Edwards. She is a health promotion consultant and writer and an activist for the rights of older people. She is a longtime member and former staffer at CPHA and is a recipient of the Ron Draper Award for Health Promotion. She has also worked as a policy analyst and writer with the World Health Organization, Participation, several provincial governments, and Health Canada's Health Promotion Directorate, where she helped organize the first International Conference on Health Promotion. There's a theme here. Peggy believes in the importance of intergenerational solidarity, and she now has a total of 17 grandchildren and great-grandchildren. She's much too young for that. Peggy, the floor is yours.
Thank you, Ian. We can put up my first slide there. Thanks. It's just such an honor to join you today from Ottawa on the original unceded territory of the Algonquin people. They've been the guardians of this beautiful land for millennia, and I'm grateful for their stewardship and leadership. I'm also very honored to be included in this very special gathering with fellow health promoters, both our speakers and participants. What a wonderful opportunity to connect with all of you, in some cases after a very long time. On this cover, those of you that know me know that I am an activist, and I appreciate Sarah's comments just in the last while about the importance of advocacy in health promotion. And I have to add here that Ottawa is not a very health promoting place right now. This illegal and nasty truckers' strike, essentially over public health issues, is hurting all of our residents, but it's most negatively impacting our most vulnerable citizens and our most essential public health emergency and protection services. The other picture here is me with my first great-grandchild, Owen, who was born during the pandemic. And when that happened, of course, I wasn't able to see him for almost 6 months. And when I did, it was wearing a mask. And I wrote Owen a letter, essentially a letter of apology that my generation was gifting him with this ecosystem that we had failed to work on, and with being born in the middle of a pandemic. So next slide. What I'm going to do is very briefly talk about the Ottawa Charter as it applies to older persons. And I'm able to do this because I've just completed working with 3 other editors, one of whom is Irving Rootman, who's on this, on a book on health promotion in older adults. And I'll come to that for in a minute. But I've got 2 pictures here. I wanted you to know that one of the most exciting contributors to the book were older people themselves. And here are 2 that spoke about their experience. Woodrow Morrison is, both of these people died during the process of creating the book. Woodrow Morrison was an Indigenous elder, a lawyer, a storyteller, and absolutely fabulous to hear his perspective of aging in his community. The other person here is Connie Swinton. She published a book at age 94 on her experience as a public health nurse. And it is absolutely fascinating because it's right from the get-go, and before we even had the Canada Health Act and universal health care. But public health nurses on the front were really dealing with determinants of health from a broad perspective. Okay, next slide, please. So just the reason I'm able to talk about and want to talk about a critical analysis of the Ottawa Charter as it applies to a particular population some 35 years later. So Irv came up with this brilliant idea of organizing the book around, in fact, the strategies in the Charter for Health Promotion. And I'll just give you a quick look at how that played out. Next slide, please. Focusing on the 5 action strategies, our question was, are they still relevant? Are they still useful? And how can they be applied and used in terms of promoting the health of older adults in particular? The first one being building healthy public policy. We had numerous wonderful contributors in this area. Some of the highlights, some of the things that come out was that we need some new narratives around public policy, particularly as it applies to older people. Innovation, and policy responses that promote health and acknowledge, and I've highlighted this word, the rights. I think that rights language as opposed to needs language was implicit in the Ottawa Charter, but we didn't often use those words. And I think there's a clear move now in health promotion towards acknowledging not just needs, but rights. One of the contributors to our book, Margaret Gillis, I think she's on the call today, I did see her name, wrote a passionate piece about the need for a convention on the rights of older people. And full inclusion of all older people within a society built on, and again, highlighted intergenerational solidarity. The whole idea of a life course approach in health promotion, it's often too late to bring in public policies when people are old, because the inequities and the disparities have been built up over the years. The second strategy, create supportive environments. This, of course, was an obvious and very important strategy. Some of the things that came out, this whole concept of an age-friendly environment, which again originated from the WHO and is now a global movement. But it's a concept that age-friendly, that's the environments in all areas, transportation, housing, health, other areas, that an age-friendly environment is what we need, both for the older population, but also it's good for all populations, in particular for children. And the idea that it needs to be, as Trevor and others have talked about, the sustainable environments in multiple settings that foster the maintenance of functionality and quality of life as people grow older. Those two words, functionality and quality of life, are important. The new WHO paper on healthy aging talks about the goal of functionality. And that doesn't mean just physical functionality. It's having the functionality, the ability to be autonomous, but to act in areas that have meaning to people themselves. The other important learning here is about rethinking life paths and transitions. You know, 35 years ago, the thing was you went to school, then you went to work, then you retired. Got your gold watch and retired. That is not the case any longer. People are living, we are living much longer, and we're moving in and out. There's a need to move in and out of learning, caring, working, taking some time off. And more we're seeing, particularly in the area of work, older adults moving in and out of those transitions. The next slide. Strengthening community action. Again, an absolutely, if not even more needed strategy. We recognize that we really have an expanded understanding of communities and community development as we knew about it in the days of the Ottawa Charter. And we have to acknowledge that. Secondly, health promotion with older adults in LGBTQ2+ communities, Indigenous, immigrant, refugee, and racialized communities, people growing older with disabilities. I know in Ontario, 1/3 of people over the age of 65 have a mobility disability. And older people living in socioeconomic circumstances, low socioeconomic circumstances, and those are most often older women. Just like to say, really appreciate the presentation from Evan, and when we look at older people in the Indigenous community, these are the people, these are the survivors of residential schools and other atrocities. And what we found and what amazes me is to celebrate in the face of those, how they still maintain their leadership and their courage, and what we can learn from elders is really important to health promotion. The next strategy, developing personal skills. You know, back when the Ottawa Charter was created, this was probably the hardest one to figure out. We didn't want to talk about lifestyle. We didn't want to blame the victim. So we came down to developing personal skills. But when we went out to look for contributors and writers in this area, they all said, you know, I don't know if that's really what we're about. What we're about is enabling environments that build, and this is a key word, resilience. That extends, it's still important, of course, healthy eating, physical activity, substance use, still important, but extends beyond that to include building cognitive reserve and vitality. And the other thing of note, it hasn't gone away, health and digital literacy, and it's back in the Geneva Charter as well. We still got a long way to go on that. And I think the term lifelong learning is important once again, is that education is not confined to young people, that their lifelong learning is a pillar of health. Next slide. And then the last strategy, reorienting health and community services. We have a brilliant chapter written by Peggy Edwards from the Ontario Health Promotion, and talking about the role of public health, critically with older people, critically health promotion, protection, and prevention. And I just want to say something about protection and what we have seen in COVID-19. And I think that there's a real need to have some constructive debates about this. And what does it mean to protect older people? For example, the crisis in long-term care, which, you know, to Canada's shame, is an abuse of human rights. But when we enact protection things that deny families seeing them, you know, like how good is this for health? I was talking to a geriatrician a couple of weeks ago, and he said, you know, those old people in long-term care, they're not dying of COVID, they're dying of loneliness and neglect. So I think there's kind of an ethical and critical debate here around the role of health promotion and health protection. We're also seeing interesting blips in the epidemiological transitions. You know, we always believed that we went from infectious disease to chronic disease, and that's what we were about. But of course, we're now recognizing that infectious disease is still a critical issue. Another area that I find really interesting is the continuity of living accommodations, housing, and care, that the two are inextricably linked. We need to address the needs and strengths of older persons, their caregivers, and their families. And they need to be, as we know in health promotion, strength-based approaches that focus on empowerment and fostering resilience. One of the still problems, challenges in our healthcare system is that it is essentially an illness care system, and public health is chronically underfunded within that system. But what we saw is that in terms of healthy aging, a lot of activities outside of health are really contributing to healthy aging, and recreation being one example. And the need for enriched social interactions and community services. So next slide, the last one. So in conclusion, is the Ottawa Charter and the strategy still relevant? Absolutely, yes. But we need to do some nuancing. We need to address the growing inequities, the longevity revolution. Now we're now talking about the fastest growing population is age 85 plus. We need to address the changes in political climate and in the physical, economic, and social environments. We need to be informed by the lived experiences of older adults, including the unique social, political, and historical context, discriminatory experiences, and the intersection of disadvantage and strength. In conclusion, my view, we need health promotion values and strategies more than ever in a society that promotes the well-being, and I like that word, of all ages. Thank you.
Thank you so much, Peggy. What a wonderful collection of presentations from our first 6 presenters today. We only have a few minutes left, so I'm going to jump right into the Q&A and pick out a couple that I think that can actually be answered hopefully concisely by the intended recipient of the question and move on. So first one goes to Trevor. What steps can those of us doing health promotion take to rebalance our efforts to improve both the social and ecological aspects of health? How can we promote values such as reverence for the earth? At what level would action be most strategic?
Well, thank you, Kendra, for the question. A couple of quick points. The first is, I think that at all levels, from the local to the national and indeed the global, we need to focus on the co-benefits of a more sustainable way of life. So whether it's the co-benefits of a low-meat diet, or whether it's the co-benefits of more physically active transportation rather than cars, or whether it's the co-benefits of reducing air pollution, or whether it's the co-benefits of increased contact with nature. Those are all things that are done for reasons of sustainability, but are also have health co-benefits. And you can do that at a very local level. Look at some of the stuff I've been writing around healthy and sustainable communities, actually for the last 20 years, but I've written a lot recently around this. But there are clear co-benefits. And with respect to a reverence for nature, I think one thing is to start engaging with faith communities of all sorts, because many of them have within their faith beliefs the idea of reverence for nature. And I think we need to be working with them on how do we make that a larger part of faith and spirituality. But for people who are not involved in faith and spirituality per se, increasing nature contact from preschool and kindergarten, in schools, and indeed at all ages, greening local communities, developing community gardens, all the ways. And one of the things we've seen during COVID is how important nature contact has been for people. So finding ways to increase nature contact, I don't think you can develop a reverence for nature unless you're in touch with nature, unless you're in contact with nature. And so that's very important. And it's very central to Indigenous beliefs. And I would just point to a line I found, or a section I found very powerful in the Truth and Reconciliation Commission, that talks about the fact that for non-Indigenous people to reconcile with Indigenous people, it's also going to take a reconciliation with nature, with the earth, with the land. And I think that that's a powerful image to also work with. So I think there's lots of ways. Thank you for the question. And that also incidentally picks up on the question from Amelia about permaculture and agroecology and the importance of the health co-benefits of moving to a more ecological agricultural system. I completely agree.
Thanks, Trevor. And perhaps, Evan, just because of the strong connection to First Nations, Inuit, Métis culture to the environment, did you want to just touch on that briefly?
Yeah, thanks, Trevor. I just want to make an analogy. When I went to Hawaii for about 6 months to work in the medical school and do some research and the like. You really hear from the Hawaiians, the native Hawaiians, that the mainlanders who come over are often completely out of sync with their environment. They have no idea where they live. They don't know the waterways. They don't know the origin mist. They don't know the volcanoes. And they just think they're in San Diego or Copenhagen, or Tokyo. And so they say, they must reconcile. In fact, they must get to know deeply. It must be in their bones where they live. We live in a beautiful paradise. We are the same way. Most of us completely out of sync with, the plants just, 30 feet away. Do you know that plant at all? Or do you know how to say hello? How are you in the local language? Most of us are disconnected. And that really is, I think, a fundamental obstacle to our wellness in situ.
Great. Thank you so much, Evan. I'm going to pose the next question to Alona. I think that this is in your ballpark. So the comment is from Glenn Laverick. Rudiger Kruk strongly implied during the 10th Global Conference that there would be a second global conference on sustainable well-being societies. Is this the version of health promotion we can expect to see at WHO during the DG's second term, and therefore no 11th Global Conference on health promotion?
Well, I know that Glenn also asked that question during the conference, and I think it's something that's being debated. I think we've had this is my personal view, this is not WHO. I think we've had a wonderful cycle of 10 health promotion conferences. I do think, and Trevor's presentation really underlined this, that we have moved a step forward. We're in the 21st century. We have a new understanding of our environment, of ecology, of even of inequalities. We have new understandings of decolonization. There has so much that has gone on, and we need a new construct of society. WHO has also created the Economic Council, the WHO Council on the Economics of Health for All, looking at the economic questions that Trevor has raised, and people like Kate Rayworth are in that council. Mariana Mazzucato is the chair of that council. By the way, it's an all-women's council, and a Director General very committed to that, and with a strong voice from New Zealand for Indigenous communities, for example. Marilyn is fantastic in that. So I think we've entered a new stage. If you were to ask me, I would see the 10th conference as the end of a cycle and the beginning of a new cycle. And so I would say, yes, our next stage needs to be a new type of series of conferences that brings the health and the ecological thinking together in the way that the Geneva Charter has outlined it.
Great, thank you so much. Now we have an open question to any panelists. So let's look at someone who hasn't responded yet. So Sarah or Peggy, and the question is from Allison. If you were drafting the Ottawa Charter today in 2022, what is one key concept that you would change or add? How about Peggy? Do you want to tackle that one first?
You know, I saw that in the Q&A and I said, oh, I'm muted. Am I muted?
Nope. No, you're good.
I saw that in the Q&A and I thought, oh God, I hope I don't get that question. I really, off the top of my head, can't give an answer. I mean, I think what we've all spoken about is updating it, if you would. I think that, as I mentioned, the strategies themselves still work. And the prerequisites for health, which later became the determinants of health, I think needs some discussion, but they're solid. They're still solid. So I think that it's some tweaking and some updating and more emphasis on the ecological approach is in the future, but I can't say right off the top of my head what I would change.
That's great. Sarah, any thoughts? I see Evan and Alona have put their hands up, so everyone who wants to can chime in. Evan, go ahead.
Thanks, Sarah. I just wanted to say that I feel like if we could name the diversity, because we are diverse, the world is diverse, if that could be named a little more explicitly, that a one-size-fits-all approach is really way too reductionist and not helpful at this point. So if we could just illuminate that a bit better, but otherwise I think the Ottawa Charter is extraordinarily good.
Excellent. Alona.
Well, I follow on from Evan. I'm a political scientist and I believe in power, or I know that everything is defined by power. And I do think we've understood better the different forms of power that have manifested themselves, not only over the last years, but over the last centuries. And I would, we have equity in the Charter, we have all these things, but we were aware of patriarchy and the feminist issues. But I think a lot of the other power structures, I mean, the extent, for example, and I notice this very much as a non-Canadian, the extent to which you now, all of you, pay respect to the land, and something, you know, I first experienced in Australia, for example, is something that has changed considerably. And so I think if I were to, you know, write it again, I agree with what Peggy said and everything, but I think an even greater awareness, which was not yet there in the 1980s, for very structural forms of inequality and discrimination. That is something that I have become very aware of, and that I would surely aim to integrate in new ways. The spirit was there. As I said earlier, we did what our awareness allowed us to do, but awareness has moved on, and that's what I would take up.
Excellent. Thanks you, Ilona. Sarah, not to put you on the spot, but any thoughts?
Well, I don't have anything to add really, apart that the Ottawa Charter is something that's still very philosophical and very large, and people on the field, they need much more concrete action. So maybe add more examples, or I know that it was done later on, but I think to make it more accessible, that would be helpful, because otherwise it's hard to really conceive what it is when you just read it. So I don't know if I make myself clear, but maybe more examples. And yeah.
Very clear, Sarah. Thank you. And I'm going to give the last word to Trevor very briefly.
I'll keep it very brief to pick up on what Ilona said, but also some of the comments in the chat, including, for example, from John Miller about the Canadian Just Transition Act and so on. The whole issue of what sort of economy do we need? An economy is tied tightly to power. You can't talk about economics without talking about power. And the misapplication of that power right now, and what sort of different economy do we need that actually respects people and the planet? That's a key issue that wasn't explicit in the Ottawa Charter, is clearer in the Geneva Charter, but still we have a long way to go.
Thank you, Trevor. So we're almost running out of time, and I want to leave enough time for our last speaker, and that's Irving Rootman, who is an adjunct professor in the School of Public Health and Social Policy at the University of Victoria and a member of the Executive Committee of Health Promotion Canada. He has been a researcher, research and program manager, professor, and consultant in the field of health promotion for over 35 years. He has published widely in the field of health promotion and was lead author and chapter author in the recently published book that Peggy talked about, Promoting the Health of Older Adults, the Canadian Experience. Irv, the floor is yours.
Thank you very much, Ian. I first want to acknowledge that I live, work, and learn on the unceded traditional lands of the Musqueam, Tsleil-Waututh, and Squamish Coast Salish peoples. With that, I would like to put there we go on the first slide. So on behalf of Health Promotion Canada, I would like to thank Ian, you, and CPHA for sponsoring and hosting this timely and excellent webinar and helping to carry the torch for health promotion in Canada. I also want to thank all of the presenters for their interesting and thoughtful presentations, not only recognizing the past achievements of the Ottawa Charter, but suggesting ways in which the fields of public health and health promotion and related fields can help improve the well-being of all Canadians and others across the world. You all have done a fantastic job. My thanks also go to the Planning Committee, which Planning Committee for this webinar, which consisted of Ian, Ilona, Trevor, Peggy, Shannon Turner, and Peggy Walsh, and myself. I don't think it's appropriate for me to thank myself for organizing and supporting this seminar. In addition, I sincerely thank WHO, Health and Welfare Canada, and the Canadian Public Health Association for supporting and organizing the Ottawa Charter Conference 35 years ago, and continuing to support the field of health promotion during that period. I want to also acknowledge the contributions of the three people that led the team that organized the milestone Ottawa Conference for Health Promotion, namely Lona, Jerry Defoe, and Ron Draper. Unfortunately, Jerry Defoe couldn't attend today, so I hope one of his friends will let him know that he was recognized. In any case, they all contributed to making the conference a success in producing the Ottawa Charter that still is a solid foundation for promoting the health of populations across the globe, as we've just heard. One recent example of this is the book on promoting the health of older adults that Peggy referred to in her presentation, that involved authors from gerontology and several other fields, as well as people working in the field that promotes health. Also, the use of other ideas that Sarah and everybody else in the this webinar put forward demonstrate the value of some aspects of the Ottawa Charter. I want to close by honoring the memory of Ron Draper, who sadly passed away in 1997 at the age of 62, shortly after a CPHA conference in which he gave a speech on influencing public policy, which I think really speaks to the issue of power that we've just been talking about. In spite of a lifelong handicap, he was able to rise to the position of Director General of the Health Promotion Directorate and was a strong, innovative, and inspiring leader. In a speech that was published in Health Promotion Welfare publication, which is shown on this slide, he put forward some suggestions for a political strategy for public health policy in which we can all play a part over time. He made 5 suggestions for starting such a strategy. In his words, he suggested that we need to gain a better understanding of the political climate. We also need to ask some critical, provocative questions about the recent history of health policy. We need to build strong, formal, but flexible networks of those who are active in healthy public policy activities. We need an immediate avenue for regular communication of case studies, analysis on public policy issues. And finally, we need an institute on healthy public policy. I'm not sure how far we have got on any of his suggestions. And I think that they, in my opinion, they are all relevant for health promotion, public health, and related fields today. If we follow them as well as the path set out in this webinar, I think Ron would be delighted and will rest in peace. Thank you all for attending this webinar and have a good day.
Thank you to all of our speakers for tremendous presentations today. And thank you for a lifelong dedication to health promotion and to protecting and preserving the health of populations in Canada and around the world. I just want to close by saying that one of the advocacy efforts and one part of a major advocacy effort CPHA will be undertaking later this year, and it's a multi-year advocacy effort, is to enshrine in the provincial public health acts all of the core functions of public health, including health promotion, which is seriously missing and a serious barrier to health promotion activities being properly resourced, both with human resources and financial resources. So look forward to some additional news about that advocacy efforts and how you can be involved in lobbying your politicians to make that change. I want to thank everyone for your great questions. I'm sorry that we couldn't get to all of them today, but it just goes to show that the wealth of conversation that needs to continue with respect to health promotion and well-being, both here in Canada and around the world. Thank you for joining us. As mentioned before, this has been recorded and will be posted to CPHA's YouTube channel. Every registrant to today's webinar will receive a notification when that posting is available. Have a great day. Stay well. Be kind to each other. Goodbye.